background, adjust background.
Ah, great.
Yes.
Okay. All right. Let me see if I get you. I didn't get yours yet. Adjust.
And then you'll see a plus when you open the arrow.
Yeah, I see camera, virtual backgrounds, avatar. Yeah, I see a plus, virtual backgrounds, plus. Add
Just
image.
press on the plus, click on the plus, and then
Yeah.
you would choose the file location, image, and then you should have saved this on your desktop. Save the IPA background.
Ah, I didn't receive it. That's just a moment.
You
I
need to
have
save
shared
it.
you on your WhatsApp. Please check.
On the WhatsApp. Ah, okay. Maybe if it's by email, it might be easier. No. No. Maybe by email is easier. Okay, let me see. Forward to.
It says double click to enter full screen mode. Yeah, we can
That's
see
good.
us.
That's good. You can start.
Are we live, Aishwarya?
Yes, you are live.
Yes, we are live.
Yes.
Hello, everybody. Welcome to today's webinar on the early diagnosis of childhood cancer. This webinar comes to you from International Pediatric Association, the Program Area Working Group on Pediatric Oncology. September is globally celebrated as the Childhood Cancer Awareness Month. This is a time to raise awareness about cancers in children and adolescents. Every year, we diagnose more than 400,000 children with cancer globally, and many of them due to want of timely diagnosis and access to good quality care, do not reach a center which is capable of treating cancer and hence lose their lives. So this is an effort from International Pediatric Association to reach out to all pediatricians from all national pediatric societies that are members of International Pediatric Association to discuss why early diagnosis of childhood cancer is important and how can we diagnose early, what are the common childhood cancers that we encounter, and what do we consider before referring these children. So these are the general guidelines. If you have questions for the speaker, kindly put them in the Q&A feature which has been introduced. To obtain the certificate of attendance, participants are requested to attend the entire duration of the webinar and fill a feedback form which will be distributed at the end of the event. And please note that the Zoom closed captions are generated by AI and there may be instances when the translations are not correct. We appreciate your understanding. So to introduce the topic and the session, we have two chairpersons. We are extremely honored to have President of International Pediatric Association, Professor Joseph Haddad, joining us today. He's a professor of pediatrics and neonatology, and he currently serves as the president of our organization. He's a distinguished leader in global health and in advancing pediatric care worldwide. Our next chairperson is Dr. Ikana Mekure. Madam is Professor of Pediatrics at the University of Lagos, Nigeria. She serves as a consultant pediatric cardiologist at the Lagos University Teaching Hospital. And she is the president of the Pediatric Association of Nigeria. And she is currently the co-coordinator of the IPA Working Group Committee on Childhood Cancer for the next 2 years. So I invite both chairpersons to today's program, and I request words of introduction from our esteemed chairperson, Professor Joseph Haddad. Over to you.
Thank you very much. I'm so pleased to introduce this extremely important webinar of this program area on childhood cancer. And I am so pleased also to be with this distinguished panel of speakers and experts. And I know personally all of you, and I hope that you will continue this, pertain these activities. And I'm looking forward to have more and more webinars of this high quality. All the success and good day to all of you. Thank you very much.
Thank you, Professor Haddad. Now I request Dr. Ekana Mekure to kindly introduce the first topic and the speaker for the first topic.
Thank you very much, Professor Nita, for that introduction. As we have heard, we're here to talk about childhood cancer, early diagnosis. And we have a very special speaker here before us in the person of Dr. Raula Farah. She is a professor of pediatric hematology stroke oncology at the Lebanese American University, Gilbert and Rosemary Chagri School of Medicine, and LAU Medical Center, Reeds Hospital. She's going to take this very important topic, and we're very privileged to have her here today. So over to you, Professor Farah.
Thank you so much. I will share my slides. Thank you so much for this introduction. I'm very honored to be here today to discuss this important topic of early diagnosis of childhood cancer. I will start with a photo of this lovely girl who had M3 acute myeloid leukemia, a very severe type of leukemia, which presented with DIC and bleeding. And with early diagnosis and prompt treatment, she is now alive and well, knowing that this type of leukemia can have very high mortality, and she just graduated from law school. So our goal is to reach this kind of result with children all over the world who are diagnosed with cancer. What I will do in the next 30 minutes, this is the outline and core topics that we will cover. The burden of pediatric cancer, why timely diagnosis is important, the risk factors for childhood cancer, the warning signs of childhood cancer, how to assess by pediatricians the possibility of cancer in a child, a quick overview of the most frequent childhood cancers, and then some summary and takeaway lessons. So what is the burden of disease now of childhood cancer? Despite all the advances in treatment and in cure, childhood cancer remains the second leading cause of death in children over a year of age, with an annual incidence of all malignant tumors of around 12.5 per 100,000 children under 15 years. The incidence of childhood cancer is increasing globally, with 300,000 new cases diagnosed a year, almost 2/3 of them below the age of 14 years, and the rest is in adolescents between 15 and 19 years. And many more cases worldwide remain uncounted and unreported due to lack of childhood cancer registries in many countries. We have to remember that there are different types of cancer in children and adults. Whether in children, we will see mainly leukemias, lymphomas, brain tumors, and neuroblastomas. Adults will mainly have lung, breast, prostate, and colon cancer. And other differences between pediatric and adult cancers is that early detection is usually accidental in children unless we really have a high index of suspicion. Whether in adults, it can improve with education and screening. The screening in children can be difficult, and most children are curable, and the prevention is not always likely. Adult cancers are more preventable. However, childhood cancers are more prone to early diagnosis, and early diagnosis is key because they are not preventable. So the most frequent cancers in children remain leukemias and lymphomas, followed by tumors of the central nervous system, then renal tumors, Wilms tumor, neuroblastoma, osteosarcoma and Ewing sarcoma, retinoblastoma, rhabdomyosarcoma, and germ cell tumors remain the most common cancers encountered in children. So it's true that children can develop various types of cancer which are different than adults, but childhood cancers remain rare, and only 1 to 2% of all cancers occur in children. However, the impact of this diagnosis on the child, his family, and the society is very heavy, noting that cancer in children is sure more curable than in adults. So significant progress has been made over the past 20 years in childhood cancer treatment. The standardized clinical protocols, guiding treatment decisions for each type for individual patients, reducing uncertainties and improving care. However, due to the complexities of therapies, children with cancer should be referred to specialized centers with trained pediatric oncology team and resources, but the role of the pediatrician remains huge because the diagnosis is made by general pediatricians, and the earlier the diagnosis, the better the outcome. There is still a difference in the burden of disease between low middle-income countries and high-income countries, where high-income countries, over 80% of children with cancer are cured, and in low and middle-income countries, less than 30% are cured. And the WHO has established a program for the next 5 years where they are trying to have worldwide at least 60% cure in all over the world. And this starts with early diagnosis. Avoidable deaths from childhood cancer in low middle-income countries can be due to lack of diagnosis, misdiagnosis or delayed diagnosis, obstacles in accessing care, abandonment of treatment, deaths from toxicity, and relapse. We also have a problem of shortage of essential medications, where about 29% of low middle-income countries still report that cancer medicines are available, compared to 96% in high-income countries. The risk factors for childhood cancer can be multiple: ionizing radiation, electromagnetic fields, chemicals, pesticides, drugs, biological factors like infections and viruses, genetic, inherited, and familial factors, which play a role in 10% of childhood cancers, but most of the time, childhood cancers occur for unknown reasons. How to reduce the burden of disease? The first key is a prompt, accurate, and early diagnosis, followed by effective, evidence-based therapy and tailored supportive care along with the chemotherapy, radiotherapy, and surgery treatment. So why early diagnosis matters? There is no doubt that there's a huge correlation between early diagnosis and better survival rates. For instance, neuroblastoma stage 1 have a 90% survival rate. Neuroblastoma stage 4 survival rates drop to less than 10%. Also, early diagnosis matters not only for survival, but also for reduced treatment intensity. Early stage cancers will require less aggressive therapy, resulting in fewer long-term side effects on the child. And also, early diagnosis will come with lower healthcare costs. So the more the diagnosis is delayed, the more the disease is advanced, and it will require more expensive and more heavy interventions. So when identified early, cancer is also more likely to respond to effective treatment. Early diagnosis sure increases the probability of survival for the child. It leads to less suffering, less expensive, less intensive treatment, and less long-term side effects. Significant improvements can be made by all of us in the children's lives by detecting cancer early and avoiding delays in care. So the factors that are contributing to delayed diagnosis in pediatric cancer, some of them are unchangeable and are due to disease characteristics, the onset, the tumor site, the aggressiveness of the neoplasm. There are also some causes related to the patient and the parents, like the patient age, ethnicity, parental educational level, parental occupation, and family religious background. But also, one of the factors contributing to delayed diagnosis is lack of awareness from primary physicians and difficulty in accessing proper health care. So timely diagnosis is everyone's responsibility. Delays may occur if the parents don't recognize the symptoms and take the child to the doctor. Delays may occur at the level of nurses, general practitioners, pediatricians, or the health system in general. So the responsibility is shared by all. and health services must commit to avoiding and eliminating delays for the sake of children. And I would like to acknowledge the initiative today of the International Pediatric Association by raising this important topic among pediatricians and discussing it today in September, which is the Childhood Cancer Awareness Month. So how to increase timely diagnosis, awareness of symptoms by families and primary care providers, accurate and timely clinical evaluation, clinical diagnosis and staging, and quick access to prompt treatment. We move on now to the 8 warning signs of childhood cancer that every doctor, parent, teacher, anybody that interacts with children should know. By knowing them, we could definitely save a child's life by having an earlier diagnosis. I need to mention that it's the duration of these symptoms. Not only these symptoms can be non-specific, most of the warning signals, as you will see, can be non-specific. It's just the duration for more than 15 days, or sometimes the severity, or that could be a warning sign. So the first warning sign is noticeable paleness or prolonged tiredness. Children like to play. They're usually very active, very energetic. So if a child is pale, very tired, and doesn't want to play with his friends, that's a warning sign. The second warning sign is excessive bruising or bleeding, and especially in areas where the child should not have bruises or bleeding, like the chest or abdomen, and not only the arms and the legs. The third warning sign is increased swelling or persistent pain in the bones or the joints. The fourth warning sign is headaches with vomiting in the morning, especially headaches waking up the child at night and vomiting early morning. A lump or mass in the abdomen, in the neck, or elsewhere, even if the child has no symptoms. Often in renal tumors, the mother is giving a shower to her child and she notices a lump in the abdomen. Another warning sign is continued unexplained weight loss. Children should be gaining weight, and continued unexplained weight loss with normal nutrition or even a normal appetite can be a warning sign. Recurrent fevers not due to infection. Fevers are very common in children. We're talking about recurrent fevers, especially low-grade fevers occurring in the evenings and not due to any infection. And finally, for retinoblastoma, development of a whitish appearance in the pupil of the eye. And theoretically, with every child's visit to the pediatrician's office, we should look for leukocoria in order to detect retinoblastoma early. Retinoblastoma detected early has a 90% survival. Detected late, it can go to the brain and be non-curable. So this is a warning sign that needs to be recognized by all pediatricians at every well child visit. So the SIOP, the CCI, the UICC have issued pamphlets and mnemonics at these warning signs, looking at the 8 warning signs of childhood cancer, and looking at the presenting signs and symptoms, common differential diagnosis with non-malignant conditions, and what kind of cancer should be suspected. For instance, if the presenting sign is low blood counts, the common differential would be infection, but the suspected cancer would be leukemia. With bleeding, the differential would be benign coagulation disorders, platelet disorders, and bone marrow failure, but also think of leukemia. For lymph node swelling, it could be infections, CMV, EBV, toxo, many infections, but it also could be Burkitt lymphoma, non-Hodgkin lymphoma, or Hodgkin lymphoma. Abdominal swelling could be due to nutritional disorders, kidney cysts, constipation, ovarian cysts, hepatosplenomegaly, hemoglobinopathies, kidney tuberculosis, but also could be Wilms tumor, ovarian tumor, non-Hodgkin lymphoma, bladder rhabdomyosarcoma, and neuroblastoma. Mediastinal masses with shortness of breath could be due to infection, but also the suspected cancer could be lymphoma or neuroblastoma. A white pupil could be congenital cataract, but in the back of our mind, we should know how to suspect also retinoblastoma. Headaches, morning vomiting, ataxia, impaired vision, and paresis can be due to migraine, sinusitis, meningitis, if associated with fever, but also to brain tumors. Bone pain, swelling of the arm or leg without trauma or infection, could be due to a bone cyst or osteomyelitis, but also to bone tumor. So these campaigns from SIOP, CCI, UICC can be placed in physician's office in order to remind them always of the signs and symptoms that could be suspicious for cancer. So childhood cancer can really have different presentations, from just simple pallor to nodes to multiple presentations, as you can see. So how can the pediatrician assess the possibility of cancer? What should he do? First, of course, he must ask for very good detailed history, past, present history, and assess the possibility of nutritional status, anemia, development, vaccination, everything. And in the back of his mind, in order to determine whether the child should have cancer, the pediatrician should ask, has the child had fever for more than 7 days and or heavy sweating? Has the child recently had a headache that has been intensifying? Does the headache waken the child? Is it accompanied by another symptom, such as vomiting? Has the child had bone pain in the last months that interrupts his activities, that has been increasing? Has the child shown changes such as loss of appetite, weight loss, or fatigue in the last 3 months? And children with cancer can come and look not so sick, like this child here on the right, who had pancytopenia and a leukemia, but is not really looking sick clinically, or like this child who is malnourished, who came with huge abdominal mass, ended up having a neuroblastoma. So they can be looking ill or not ill. Still, we have to ask all these questions. And then we need to observe, feel, and identify on physical exam petechiae, bruises or bleeding, severe pallor, any eye abnormality, leukocoria, new onset strabismus, aniridia, heterochromia, hyphema, proptosis. Look at swollen lymph nodes, anything larger than 2.5 centimeter, hard, painless, lasting for more than 4 weeks needs an evaluation. We look also for focal neurologic signs and symptoms who are sudden or progressive, convulsions without fever, unilateral weakness, physical facial asymmetry, changes in consciousness, in mental status, in behavior, confusion, loss of balance when walking, limping from pain, difficulty speaking, blurred, double, sudden blindness, palpable abdominal masses, hepatosplenomegaly, or enlargement and masses of other areas in the body. You can see how the petechiae can present in both benign and malignant lesions. You can see the huge lymph nodes for this girl who had a nasopharyngeal carcinoma. And you can see here the leukocoria with retinoblastoma in this child who had a white pupil. So next step for the pediatrician, so any suspected sign or symptom of cancer, the best and only procedure is to refer the patient immediately to a specialized center. And here, on the assessment of the pediatrician, there could be classified as possible cancer or very severe disease based on the history and findings that we discussed. It could be some risk of cancer, or it could be that does not have cancer. At that time, then we can proceed with the regular pediatric visit. So in the back of the mind, in each visit, searching for signs and symptoms of cancer is in the background of each pediatric visit. So ideally, the first step is diagnosis. The second step is refer to a specialized center. Third step is staging and stabilizing the patient. And the fourth step is prompt treatment. So the diagnosis can be made in the pediatrician's hospital if he has access to a facility that can do that, or in the referral center, and they will require imaging, specialized lab testing, all kinds of now molecular studies, labs, etc. Staging is very important. This is a child that presented with a huge adrenal mass. He actually presented with early puberty, and he came to the hospital about 5 times to the emergency room with different complaints of having hair, pubic hair, early pubertal development, but he was really very young and looking like a 10 or 5 patient, and he ended up having a huge adrenal tumor, which ended up at diagnosis being metastatic to the liver. You can see all the liver metastases, and to the lungs. So had this child been recognized from the first visit that this puberty starting so early and going so fast is abnormal, he wouldn't have been diagnosed at such an advanced stage and would have been more curable. So how to improve early diagnosis? Definitely awareness campaigns, educating parents, teachers, and healthcare workers, training primary healthcare providers on warning signs of cancer, strengthening the referral systems to specialized centers, securing rapid access to diagnostic imaging, pathology, and labs, and having in each country national pediatric cancer registries in order to track the incidence and the outcomes and to guide public health planning. So this is a child also that came into our hospital with M3 AML, and a type of acute myeloid leukemia that could be very fatal. He had DIC, splenic, and intestinal infarcts at the time of diagnosis. He is now a young adult and has been cured because all these, he was transferred immediately to our center once the diagnosis was suspected, and diagnosis and management was very prompt. You can look how leukemia cure rates have improved markedly during the last decade. This is a slide from Dr. Pui, published in the New England Journal of Medicine. You can look at survival rates in leukemia. We're talking about acute lymphoblastic leukemia of 9% in the 1960s, and you can see now how the cure rates have reached almost 92%. And this trend is seen in almost all the types of cancers. You can see how the cure rates have improved a lot, but we are still not doing so well in brain tumors. And this is, I want to just have one slide on brain tumors because diagnosis is still delayed in brain tumors, and often they have seen many doctors before reaching the pediatric oncologist or the neurosurgeon or the neurologist. Of course, when there are neurologic symptoms, the diagnosis is easy or deficits, but sometimes the diagnosis is not so obvious. And I want to insist on this point published and promoted by the Pan American Health Organization about the altering or changing behavior, change in school performance, change in sleep patterns, change in behavior, headache that wakes up the child in the morning, change in frequency or type of existing seizures, unexplained change in corrective glasses prescriptions. These signs are not always so obvious, especially the changes in school performance. This is why teachers, parents should be aware of brain tumors. And this is one of the cancer awareness campaigns that we did in multiple public and private schools, about 100, and we reached about 80 public and private schools in order to raise awareness among teachers and parents, especially on the problem of brain tumors. And we had published awareness cards in 3 languages with the warning signs of childhood cancer that reached over thousands of parents from these schools at home, where they can read them, look at them, and have the warning signs of cancer available in their homes and also in pediatricians' offices. As you know, the children with cancer undergo several procedures during their treatment. They undergo long chemotherapy sessions. Some of them require radiotherapy. The treatments are very long, they're very costly. The duration of leukemia treatment can be 2 to 3 years, and for solid tumors, 12 to 18 months. So the earlier the diagnosis, the easier the treatment. Adolescents have a very hard time. In addition to all the problems, they have a lot of psychological issues dealing with cancer. So I insist again that the earlier the diagnosis, the better the outcome. Of course, good relationships with the staff are very important. Accepting the diagnosis is very important. Medical treatments and play therapy are combined. And despite all this, undergoing cancer treatment is very difficult for parents, for healthcare workers, and for the healthcare system. So as a small takeaways, cancer in children is rare and curable. Cure rates are around 80%. The treatments are long, yes. They are costly, yes. There's a big psychological and financial impact on the entire family and the whole society. Cancer detection must be part of primary care. Training healthcare workers is crucial and awareness is key. Early recognition can save lives, and improving access to childhood cancer cares is highly cost-effective, feasible, and can improve survival in all income settings. Pediatricians have also to be aware of cancer predisposition syndromes. We can probably have another day, another session on all the genetic and inherited syndromes which predispose children to cancer and familial cancer genes. We always see on the covers of magazines, there are no more cancer, we found the magic bullets, we found a cure. But of course, although cancer cure rates have markedly increased, there are still a lot of children who are affected by this disease. And the best way to fight this disease is to diagnose it early and have a high index of suspicion. All these children have had cancer when they were children, and now they are all young adults. And this is thanks to early diagnosis, proper treatment, and improvement in supportive care. Together, we are stronger. And as you can see, this is Dana. Dana had a periorbital rhabdomyosarcoma, which was very aggressive. This is her when she was a child and getting treatment for chemo. She always wanted to be a normal child and have a normal childhood. And now she is one of the volunteers in our NGO, Chance. And she is the one who wanted to put her photo for Gold September, raising awareness on all kinds of cancer, especially ophthalmic and ophthalmologic cancers, because she had to see many doctors before the diagnosis was made. And now she is a young adult living and leading a normal life. And also, I don't want to underestimate the role of the community in helping doctors raising awareness against cancer. This is Serge and Ghassan. They are two ultra-marathoners who went to the desert in Morocco and ran the Marathon des Sables, a very challenging 250-kilometer race, in order to raise awareness against childhood cancer and support the treatment of underprivileged children. So together we are stronger, and if we put our hands together, we can certainly raise awareness, cure more children, and make an early diagnosis. Thank you so much for your attention and for the opportunity to present this today with the International Pediatric Association.
Thank you so much, Dr. Farah, for that excellent presentation. Very informative. There are some questions on the Q&A, and I think I saw a hand that was raised up earlier. Before we go into the panel of discussion, I think we should just address those three questions quickly with Dr. Farah. So if we look at the first one there, given the prevalence of hematological childhood tumors, how can hemato-oncologists cope with this rising trend, putting side by side the risk factors in societies beside early diagnosis?
I think you can hear me. Thank you, John.
Yes, we can.
Thank you, Dr. Kimjal, for this question. I think everybody has to be aware of these hematological cancers that can occur, especially leukemias, and have a high index of suspicion. And at any time that they see anything abnormal from the signs and symptoms that we mentioned in the talk, to refer immediately to a specialist or to refer to do lab testing, and not let the parents be afraid of the diagnosis of cancer, but empower them and encourage them without, of course, scaring them. Childhood cancer continues to be rare, and there are so many benign hematologic diseases which can occur when you have disturbances in the blood test. So they don't necessarily have to think immediately of cancer, but definitely it's worth investigating if there are any hematologic disturbances suspected.
Thank you. There's another one: considering the cost implications of treatment, especially among low-income earners, what policy can the World Health Organization and other World Health decision-making organizations make to ensure those with these conditions are adequately and indiscriminately taken care of?
That's a very good question and a very long topic. You know that the International Society of Pediatric Oncology, the SIOP, is the organism that supports scientists improving science for children with cancer. And in parallel, you have CCI, or Childhood Cancer International, which has an official relationship with the WHO and is the voice of the parents, families, and organizations towards getting the rights of the families in access to care listened to, and getting their rights in accessing adequate treatment in all the countries. There is still a lot to do, but CCI has 190 organizations in 5 continents working towards the goal that you just mentioned. And there has been a lot of improvement made, and the WHO has many programs that are actually targeted towards this goal. And they have specific countries where they have more actions, countries with big needs. They also have a program where they with access to medications to all. And the big, I would say the big intervention is called Cure for All, where the goal is to have at least 60% cure in childhood cancer worldwide. I hope that answers your question.
Thank you. There is one question here, not directly to you. So I am a pediatric surgeon. I work in East London, South Africa. Can I become a member of IPA? So the way IPA runs is that we have member societies. And so being based in South Africa, you would need to join the Pediatric Society, the South African Pediatric Association. And it is through that pediatric association that your association would be part of IPA. So most of us in the room here belong to societies in our countries, and our societies are member societies of IPA. I hope that answers your question. There's one last hand up very quickly. Let's see who. You can unmute and ask your questions or write it in the chat. I can see a hand. Is it deliberate or by error? In case it's by error, I think at this point in time, we can move on to the panel discussion, and it is my pleasure to welcome back Dr. Nita, who is going to moderate the panel discussion. We have excellent panelists who are ready to deal with cases that will drive the points in the lecture home further. Thank you.
Thank you, Dr. Ikenem. So moving on with the panel discussion for today, I would like to invite the panelists to the session today. We are joined by Dr. Rawad Rehani. Dr. Rawad joins us. She's the chairperson at the Department of Pediatrics at the King Hussein Cancer Center, and she's the president-elect of Pediatric Oncology in Eastern Mediterranean Group, which is yet another professional organization which is working towards improving cancer outcomes in the Middle Eastern region. We are fortunate to have Dr. Mukesh Dhankar with us today. He joins us from New Delhi. He's a professor of pediatric hematology and oncology in the Department of Pediatrics at Kalavati Saran Children's Hospital in New Delhi. It's one of the largest pediatric hospitals, medical colleges in the country. We also have Dr. Alia Ahmed. Dr. Alia is a professor of pediatric hematology oncology at the UCHS, the Children's Hospital at Lahore. She's a primary delegate for St. Jude Global Alliance Partnership, and she's a member of the advisory board of St. Jude's Together and the site director for SJ Cares Hospital Registry. That's the hospital-based cancer registry in Lahore. So over to the session. We, in the next 40 minutes or so, we'll be discussing about childhood cancer, all what Dr. Farah just discussed, why it is important, and we'll discuss specific cases of children who present to pediatricians with cancer. And you can see how common it is, a presentation, because they are the first contact points for these children. And if we diagnose them correctly, we are able to get them a cure, as was mentioned in the earlier presentation. So this has already been discussed, but I would like to point out a statement from WHO fact sheet of 2021, which says that the likelihood of survival of childhood cancer depends on the country in which the child lives, which is a really, really sad aspect actually, to point out that, treatment, it's not dependent on the biology of the disease. So it's not dependent only on the how aggressive the disease is or what is the stage of the tumor. It is also important where the child lives. So that highlights all the access issues that we have discussed so far, that these children, if they are treated in centers or in countries which have good access to treatment, their outcome improves immensely. And the children, again, another important aspect of childhood cancer is that the childhood cancer is very, very different from an adult cancer. So we should know that adult cancers can be screened for. So all of us would know about, cancer screening in adults, like oral cancer screening or breast cancer screening, cervical cancer screening. There are so many ways of screening for cancers in adults, whereas in pediatric cancers, we're not able to screen them. They are very, very aggressive cancers. So by the time they present to us, they are usually in early advanced stages. But if we diagnose them correctly, they are generally sensitive to treatment that we offer. So chemosensitivity is quite good. So hence, we are able to cure them much more than that of adult cancers. So these are the ways in which childhood cancers can present to us, which has already been shown. So there is a multidisciplinary team. It takes a village to treat a child. So it starts from the diagnostic services to the main treatment that you can offer, and to all the support staff that we have, like nursing, pharmacists, social workers, your whole psychosocial team, your nutritionists, hygiene support, schooling, education. All of this is important to get a child towards cure. So having said that, let's come to the first case of the day. So this is a 3-year-old child. So we are highlighting 4 important presentations of childhood cancer today, and we'd request the panelists for their opinion on each of them. So this is a 3-year-old girl who has been having fever off and on for 2 weeks, high grade 2 to 3 spikes in a day, feels tired, pains in her leg. She was previously very well, and she prefers not to go to school because she has leg ache nowadays. She also has some running nose, so the parents just think it's a viral fever. She's evaluated by a pediatrician. On examination, she has mild pallor. She has few bruises here and there, and there is a liver which is enlarged 4 centimeters and spleen around 2 centimeters. So that brings me to my first question. What are the common causes of hepatosplenomegaly? So this is a child with fever followed by hepatosplenomegaly. Is a very common presentation in pediatric practice. So Dr. Alia, the first question to you. What are the common causes of hepatosplenomegaly in children?
Thank you so much for having me here. Actually, when a child comes with fever for 2 weeks, over 2 weeks, in liver and spleen, and then also having some bruises, having evidence of infection, 3 cell lines involvement is there, then I think the pediatricians should think about malignancy in their mind, because many of these children, they continue to be treated for infections long time before it gets too late. So if any child who comes with fever over 2 weeks, liver, spleen enlarged, bruising, bleeding tendency, and pallor, we should keep in mind that it can be a lymphoblastic leukemia or lymphoma, mainly acute lymphoblastic leukemia. So leukemia should be one of the major differential in our mind as a general pediatricians in our clinics. Thank you so much.
Thank you, Dr. Alia, for highlighting that although there are common infections which are present with the same presentation of fever with hepatosplenomegaly, but once the fever is like beyond 1 to 2 weeks, we should definitely consider malignancy as a possibility. So that brings me to the next question, Dr. Mukesh. What are the clues towards malignancies in children who present with hepatosplenomegaly and fever, who are probably were considering leukemias, lymphomas, etc. in those children? So what are the clues you would look for in your history?
So right. So the clues which I would like to see and consider malignancy would be if the child has some constitution features like B symptoms in the form of fever, weight loss, night sweats. Child has rapidly developing hepatosplenomegaly. Child has bone pains, lymphadenopathy. Child has some abdominal distension. These would be the things where I would like to consider malignancy specifically, and thereafter I would like to investigate.
Thank you very much. So, so any child with an associated symptom, like very, very suspicious symptoms of bony pain or patient who presents with lymphadenopathy definitely requires further evaluation. So Dr. Rihani, what are the investigations that you would advise pediatricians to do? If you're suspecting, I think for all fevers, they would generally be doing a complete blood count. But in addition to that, what all would you ask for? And in the complete blood count also, what would you want pediatricians to look for?
Thank you so much. I think, first of all, the complete blood count comes with a lot of parameters that we should all be looking at, such as the differential. I think looking at the ratios of lymphocytes and neutrophils is very important. And some in these cases, the lymphocyte count is predominant in case of ALL, for example. And also the most important one is the peripheral blood smear to look at the blood film for abnormal cells such as blast cells or shift to the left or atypical lymphocytes. These are very informative, and also looking at the other parameters such as the platelet count or there are any abnormal cells, and also if they're abnormal shapes, for example, or small size. In addition to the CBC of the and the blood smear, it's very important to look at the chemistry, and also that includes, of course, the uric acid, just in case there's a tumor burden, the potassium level, the calcium, and the phosphorus. These are very important to check in cases of leukemia, if we're considering, or high burden of lymphoma, for example. The other thing these patients deserve that we should consider in cases patients with lymphadenopathy to look at consideration to have a biopsy from the lymph nodes, and also in case of suspicion of the leukemia to get a bone marrow evaluation. However, these should be performed not by the pediatricians. They should be referred to specialized centers. For example, why do we need the referral with the bone marrow biopsy, the aspirate biopsy? It requires expertise, and also there are lots of tests that are very specialized. For example, sending the samples for flow cytometry, for tumor markers, and cytogenetics is very important to complete the workup for these patients and try not to repeat it. If you do it by the pediatrician, the oncologist or the referral center might need to repeat and subject the patient to additional testing or agony. And also there are tests that only available in subspecialized centers, for example.
Thank you very much for detailing those investigations. So now again, the question to you, Dr. Rihani, that so now we have made a diagnosis on the basis of a peripheral smear, and then there is a biochemical evaluation done. So we are considering if the pediatrician has accounts of, say, like 100,000 WBC counts. So they are planning a referral. So what are the special considerations that should be made while planning this referral so that the child reaches the oncology center safely?
It's I think the most important thing is proper communication, and we should attempt to communicate with the primary team or the treating team or the subspecialized center, like pediatric oncologist or cancer center, and provide detailed history and examination and findings for that patient so that they have the comprehensive picture, and also prepare a detailed summary about the case that we are planning to refer refer. Meanwhile, those patients, if they are febrile, they should be covered by IV antibiotics to cover the risk of infection. These patients are often neutropenic, or they are already having infections ongoing or at risk of infection. And also these patients, because of the tumor burden, such as the 100,000 that you mentioned, there's a chance for tumor burden and tumor lysis. So these patients should get IV antibiotics that's free, IV hydration fluids that's free from potassium, of course, accompanied by diuretics. And often these get 1.5 maintenance, but at your center as pediatrician, you can just start regular fluids as maintenance. Also, the most important thing, if the patient is having low platelets or signs of bleeding or petechial rash, there's a risk of bleeding, this patient can get platelet transfusion. Very importantly is that you should not try to give steroids and try not to get a biopsy by yourself. And often it's better to refer these patients to the subspecialized teams that are really well trained to handle and have the capacity to handle those complex cases.
Thank you very much for detailing those referral points, because these are things which should be carried home by every pediatrician and pediatric trainee who is attending today, that if you are referring, connect to the team whom you are referring to, speak to them, give a proper summary, and do not start steroids. Thank you for highlighting those points, Dr. Rehani. So now we come to the second case. So first case was fever with hepatosplenomegaly, where we highlighted how a usual child with lymphoblastic leukemia or myeloid leukemia would come to you. In the second case, we are highlighting abdominal masses. Again, a very, very common presentation for childhood cancers. We heard all the presentations of childhood cancers and the warning signs from Dr. Rula Farah earlier. So abdominal mass can be very, very alarming for a parent. And from, if you talk about abdominal masses per se, it could be something very benign like a cyst, or it could be something which is very, very sinister like neuroblastoma as well. So, and again, it could be something which comes in with a lot of symptoms, or it could be something which is just picked up during bathing like was shown earlier. And so there is a big spectrum of benign to malignant and to even infections, like countries like low and middle income countries see a lot of infections, including tuberculosis, which come with abdominal masses. So here we have a baby. It's a 2-year-old boy who's come with, he's a well child earlier, no symptoms at all. Mother again classically notices while giving a bath, there's something she feels in the abdomen, and she goes to a pediatrician. So here again, the primary contact point is a pediatrician who examines the abdomen, looks at the abdomen and finds that there is a very soft mass. He's not even sure whether this is something which is abnormal. So, and that is felt in the right lumbar area. So coming to the first question, Dr. Ahmed, what are the common abdominal masses that you find in children that you need to be worried about?
Thank you so much, Dr. Nita, for highlighting this case. I think for small children having abdominal mass picked up by the mother or the relatives or by the doctor, we should have the differential diagnosis of mainly the child is well. We think about maybe Wilms tumor, but if the child is not very well, very pale, anemic, then we think about neuroblastoma, and it depends on where is the site of the abdominal mass. If it's on the right side, or it might be as a young child, can be hepatoblastoma, and then the Wilms tumor can be on either side, and neuroblastoma can be also on the right or left side. But usually Wilms tumor children, they are quite well, as compared to neuroblastoma children who are having pallor, anemia, and they are irritable. And the other differentials can be suprarenal masses like adenocortical tumor, but they are more common in maybe over 2 years of age. And then the other differentials can be germ cell tumors, sarcomas in the abdomen. So, but for a well child, is a small child and picked up by the mother while giving birth to the baby, I think Wilms tumor is our first differential, and the pediatrician should go for urgent ultrasound and further refer to the specialized center for biopsy or further investigations like CT scan or MRI. Thank you so much.
Thank you very much. So now we come to the evaluation. So what, as in when the child comes to the pediatrician, what all should the pediatrician look for in the clinical findings in common abdominal malignancies? Dr. Dhankar?
Right. So as it has been just mentioned that there are various causes of abdominal masses, but the four more common, most common abdominal masses seen in children are Wilms tumor, hepatoblastoma, germ cell tumor, and neuroblastoma. This could be just presenting from a simple painless mass associated with constitutional symptoms like fever, malaise, bone pains. So it depends what malignancy we are dealing. So it could be a simple abdominal mass, flank mass specifically, which could be just a Wilms tumor, to a germ cell tumor, specifically lower abdominal mass with obstructive features, or it could be just painless, to neuroblastoma, where we could have systemic manifestation like raccoon eye, blueberry muffin skin lesions, bleeding manifestation because of the bone marrow involvement. So it could vary from a well child to a very sick looking child with the features of metastasis like bone pain, skin lesions, raccoon eye. And it thereafter the investigation would help us. These are the clinical clues what we have, from which we can differentiate what we are dealing with, but we would need further evaluation to find out what exactly we are dealing with.
Thank you very much. So like you mentioned, these are the four most common pediatric abdominal onset origin malignancies: neuroblastoma, hepatoblastoma, Wilms tumor, and germ cell tumors. Again, all four of them come to with varying complaints, of some of them with just a mass, some of them with other symptoms like Dr. Dhankar just mentioned. So again, the next question to you, Dr. Dhankar, what are the common investigations that you will advise? So now the pediatrician has palpated there's a mass, he's suspecting a malignancy. What should be the next investigation?
Right. So here I would like to start from the baseline things like CBC with the peripheral smear, because abdominal mass could be because of the Burkitt also. So CBC with peripheral smear, I would like to have biochemistry parameters with me. I would also like to do tumor markers because it could be because of the germ cell tumor or hepatoblastoma. Definitely thereafter I would like to do imaging, in which I would like to do X-ray, ultrasonography, or CT scan, in which with these imaging I would like to see the origin of the mass, its relationship with the mass, and relationship with the other organs with the mass. I would also like to identify the site from where I would like to do biopsy. And once I have identified the site, I would like to do a biopsy, in which I would also not just see the histopathology, but I would also like to do the immunohistochemistry and molecular studies if available. And for staging investigation, we would require, depending on the malignancy, PET scan or MIBG scan specifically for neuroblastoma, or bone marrow biopsy if needed as per the mass.
Yes. So for most of the investigation, most of the abdominal tumors, imaging is usually an ultrasound initially, followed by either a CT or an MRI as required. And like mentioned, it is required to know where the tumor is arising from, and also its relationship, so that we can relationship to the organs nearby, where is it metastatized, so that we can plan the biopsy properly and do the staging workup. So Dr. Rawad Rihani, so what are the considerations here again? So here is an abdominal mass baby. The child is very well stable. So can we wait or should we refer early? What are the points that you would consider while counseling the family for a referral?
Thank you again. I think again, I would like to stress on communication, a very good communication with the primary team that we are referring to. I think it's very important to convey the detailed status of the patient and the history and the findings. But also here we've stressed the importance of counseling the family about the possible diagnosis, what to expect, what we are thinking about. And also we need to stress to them that in this case, this kind of tumor that require multidisciplinary care, and there are multiple specialties involved in the care of these children. Having said that, we should keep in mind and keep a very positive outlook for the family, and provide them with hope and courage, because the majority of these abdominal tumors have good prognosis. So again, we cannot overstress the value of great communication with teams, doctors, and families.
Very true. And you mentioned hope and courage. So I think that's the most important thing, because pediatrician is your primary care point. That family would have been going to the pediatrician for many months earlier or many years earlier in many cases. So what the pediatrician counsels is something that that will make a lot of change to them. So if there is a counseling with hope and courage, then most families will go and get the treatment done. But if the pediatrician himself or herself says, okay, this is a very bad disease and it's a very poor outcome, many families may not even go to an oncology center. So like you rightly mentioned, the correct information initially is very important for families who are diagnosed with cancer or suspected to have cancer. Now we come to our third case. So again, a very, very important presentation of a malignancy which is potentially curable, but if it is not detected on time, it can take lives of children, not just the vision of the child, but even life of a child. So this is the presentation of retinoblastoma. It is that the presentation is called white reflex or leukocoria. It's an abnormal white reflection from the pupil, which is often detected in photographs. Nowadays, there are even apps and phones which can detect it and flag it for you. So this is a very important warning sign, one of the warning signs which was shown earlier. So here again, we have a well baby. So it's the myth that cancer, if there is cancer, there has to be a lot of symptoms. A lot of parents who come to us tell us that the child is absolutely well otherwise. So there's no feature of a malignancy. It's not like all cancer should have weight loss or all cancer should have fever. There are many cancers who come with children who are apparently well in the beginning. So here is a 3-month baby who has just come for a routine vaccination visit, and mother just accidentally mentions that I found a small pearly white spot in the eye 2 days ago. Can you have a look at it? And this is how the consult is done. So Dr. Alia, what are the common causes of white reflex in children that pediatricians should be aware about?
Thank you so much. Usually when a small child presents to a doctor or the vaccination center, and the mother, somebody picks this finding in one or both eyes of a child, small child. I think being pediatricians, retinoblastoma should be at the first differential list, because to pick retinoblastoma in time and to treat and refer to the specialized center, it can save not only the vision, but also not only the life, but also the vision of the child. But at the same time, we should keep in mind about congenital cataract, Coats disease, persistent fetal vasculature, and corneal opacity. And something post trauma also can cause some corneal opacity and retinal. But the most fatal differential diagnosis is retinoblastoma to be picked. So that's why if the parents or the relatives or in the vaccination center or a general pediatrician or general physician picks this finding, told by the parent that they are to the specialized center for retinoblastoma, not because if we delay the diagnosis of retinoblastoma, it spreads to
I think there is some.
It looks like, there's some internet issues. Maybe Dr. Nita, you can continue from there.
I think I'm going to the next question anyway. Hopefully she can join by then. So Dr. Dhankar, when there is a child who is suspected to have a white reflex, what should the pediatrician do next? Where should you refer? What are the things that you would look for in a child with the white reflex?
So we should have a clinical suspicion with any child who has a white reflex. So it's a very simple test. We do we throw white light with a torch to both eyes equally, and we can usually it is red, but if it's a white reflex, that is a first suspicion which we tend to see. The other second most clinical manifestation is the strabismus, which is not resolving, the squint. Thereafter, it could be poor vision, abnormal eye movements, or it could proptosis if it is very severe. So, and the good part, as you were just mentioning, Dr. Nita, there are abs, and we can also compare with our past photographs also, where we can see a white reflex. So, and all these things combined, and if there's a family history of retinoblastoma, our suspicion should be even higher. So these are the things which would make me suspect that probably we are dealing with retinoblastoma, and the child should be referred quickly and appropriately. That's all I would say.
Thank you very much. Like you mentioned, if somebody has a new onset squint, not just for retinoblastoma, it should be for brain tumors as well. We should
Yes,
keep
yes.
that. So pediatrician should be very, very alert. And in general, conversation with the children also, with the families also, can just mention that if you find something like that, when you take a picture for anybody in your family, please do report, because it's something which you pick up quickly, you have a very good outcome. So coming to the next case, we have Dr. Alia. How can pediatricians screen for retinoblastoma in a routine practice? What all can they advise, or in a clinical exam?
I think for pediatricians, they should, if they suspect that it can be retinoblastoma, ideally it should be referred to the pediatric ophthalmologist, but they can also do the red reflex test to see the, no, because we can find the, oh, sorry, this one,
Yes, yes.
Dr. Raman had to tell. No. So normally they should be red glow, but if it's not normal, then we see a white, dull or absent reflex because of the opacity in front of the macula in the form of retinoblastoma mass. So urgent evaluation is, because time is the key here. If we send the child to the trained pediatric ophthalmologist and pediatric oncology team, they can assess, do further tests, confirm it, and can proceed with the treatment. And then there's need of counseling of the parents also, because to tell the parents of a very, very well child that it can be cancer in the eye, it's a huge blow to them. So doing the counseling, they should be referred to a specialized center to confirm the retinoblastoma diagnosis. Thank you.
Yeah, exactly. That brings me to the next question. How do you counsel the family? It's quite a very something which requires a prompt evaluation. And so how do you counsel these families, Dr. Rawad?
So we have to communicate to the family that this white reflex is another normal finding, and there's no need to wait. This is actually an urgent condition that requires immediate attention, and it's a rapidly progressing finding that can be life-threatening to the vision, to the life, and to the vision. So we need to communicate this really clearly to the family. No need to wait, no need to reassure the family or delay. And the way we do it, we should refer these patients to specialists. So they need to go to the pediatric ophthalmologist, to a retinoblastoma unit, or a pediatric oncology center. And that's how we should really deliver that. We should really stress on the urgency of the situation.
Thank you very much. I think all our panelists have highlighted the fact that referral has to be quick, because it's a question of vision, salvaging vision, and at times it's a question of even salvaging the life of a child. So very, very urgent referral is required from our pediatric colleagues for if you ever encounter white reflex. So even if you have a doubt, it's okay to get it evaluated by an ophthalmologist. So that brings us to our last case today, which is bone tumors. Again, because bony pain is a common complaint in children, a lot of us, we've learned what is growing pain. So a lot of children, when they complain, when they come to a routine pediatric practice, usually it is attributed to a growing pain and they are reassured. But many a times it could be something more sinister, like a leukemia, or at times it could be bone tumors as well. So here again, bone tumor, if there is a swelling and pain, it could be a very big spectrum from something very benign to something very malignant as well. So again, delay in diagnosis can lead to loss of limb or loss of life as well. So here again comes the role of our the primary care pediatricians and orthopedicians. So this is our case, a 15-year-old boy who's come with pain and shoulder in the left, pain and swelling in the left shoulder. And as usual, as is usually the case, there is some history of trauma usually, because they remember that this happened after a trauma. So many times it is attributed to be trauma related or a fracture related, etc., whereas actual underlying malignancy is often overlooked. So they have come to the pediatrician with a pain. They could go to an orthopedician as well. So this is an image you can see. So my first question to Dr. Alia, what are the common causes of bony swellings in children?
Yeah, thank you so much. I think for for early detection of bony tumors. If a child has, as the case discussed, he has swelling and he has pain in his shoulder and there is a past history of trauma. So usually the delayed diagnosis is the parents think that it can be trauma and they are in a denial phase. And sometimes they are being treated for fracture. But I think any bone swelling and bone pain in a child, usually sarcomas, they are in older children, but any age can be presented with bone sarcoma, especially Ewing sarcoma. So the children having these swellings or pain, they should be referred urgently to the orthopedic surgeon or the pediatric oncology team, because we need to do further investigations in an urgent mode, because if we do not create urgency, they can go into upstaging of the disease. So any child, as we know that awareness campaigns for any cancer like breast carcinoma, that any lump noted, they should proceed for detection of cancer, whether present or not. So I think we should create awareness among pediatricians that in children also, any lump, any swelling in bone or any part of body should be considered malignancies until proven otherwise. So because if we detect them in early stage, they can be treated with less toxic protocols. So for pediatricians, very important if parents bring a child with bone swelling or bone pain or history of trauma, because trauma hits the attention of parents, because they just they don't want to think about it can be cancer, and they just blame that it was a trauma, so it cannot be a sinister thing. But I think pediatrician should keep in mind that it can be malignancy, it can be sarcoma, and should be referred to the specialized center for further investigation and to confirm or rule out bone sarcoma. Thank you.
Thank you very much for highlighting those two important points, that any swelling should be evaluated, and even if there's a fracture, please look for something sinister underlying. So Dr. Dhankar, most of the families would get an X-ray either by themselves or by the pediatrician or orthopedician would ask for it. So what are the findings in an X-ray which would guide you towards a malignancy and not a benign lesion?
Right. Very good question. There would be many things which can help us, which gives clue. So in the benign lesions, they are usually they usually have well-defined margins. There is a narrow zone of transition. Periosteal reaction is either absent or it's minimal, and it's often an incidental finding. They usually do not present with bone pains and something like this. And the malignant lesions on imagings usually have ill-defined margins. They have wide zone of transition, and they have aggressive periosteal reactions in the form which could be sunburst pattern, onion skin, Codman's triangle, which we would be discussing further. And cortical destruction is another thing, and fracture is also a possibility in such cases of malignant lesions. And coming on to this difference between Ewing sarcoma and osteosarcoma, the first and the foremost thing is the age. The Ewing is usually either in the childhood or an early adolescent. The osteosarcomas are usually in adolescents or adult age groups. The site in the Ewing is the diaphysis, whereas in the osteosarcoma it is the metaphysis. The X-ray findings in Ewing sarcomas are the classical mouth-eaten lesions along with skin lesions, periosteal reaction, whereas in the osteosarcoma is a mixed lytic sclerotic lesion with sun-based periosteal reactions with classical Codman's triangle. And in Ewing sarcomas, they usually have the systemic features like fever, weight loss, whereas the osteosarcomas are usually associated with only pain and swelling and pathological fractures if large.
Thank you very much for highlighting those differences and highlighting the difference between a benign and a malignant. So any periosteal reaction, always get it evaluated, and any suspicious lesion as well, always get readded. So if a pediatrician is to refer the patient, when should it be referred? So it should be, there's always a concern that I keep seeing so many of these bony pain all the time. So when should I actually refer? Dr. Rawat?
Yeah, thank you. So referral should always be very early on, as we mentioned. However, we can perform initial evaluation just to make sure this is not related to trauma or other infections. So we need to get a detailed examination, detailed history, especially presence of systemic signs and symptoms such as fever, weight loss. And the investigation that we could initially do is getting an X-ray always as a first step, as a first investigation. And afterwards, if we define there is something abnormal there, we can proceed for MRI to define the extent of the bone involvement, the soft tissue involvement. And if we do, for example, suspect a metastasis in the chest, we get a chest CT scan. We can get some blood tests such as complete blood count, ESR, ALP, and LDH to just look for tumor burden or tumor markers. However, we should never attempt to get a biopsy, and that should be reserved for the specialist center. This is very important because at the centers we get specialized testing. In addition, we might be needing to give, or most of the time we might need to give neoadjuvant chemotherapy. So these are the instances where we need to give the initial testing and refer the patient as soon as possible.
Yeah, so that's my next question as well. So many a times the patient is with an orthopedician, and the orthopedician says, okay, let me go in and see what is it. Is it an infection or not? So do you have any pointers for even primary care orthopedicians?
So yes, I think before referral, we should not try to attempt any unplanned surgery or curettage, and trying not to get any biopsy outside the specialist center, which in this case can compromise the limb salvage. And of course, we should try to avoid unnecessary empirical antibiotics for the bone swelling or the pain, unless there are signs or evidence of clear infection.
Very true, because many a times if it's an aggressive malignancy, there'll be signs of inflammation as well. So there'll be pain, there'll be tenderness, and it's often attributed to an osteomyelitis, and there may be even fever as well. So like you very rightly said, if you're suspecting bone tumor, refer quickly, avoid wasting time by antibiotics, etc., which could be even given at the next center as well. So I think that brings us to the end of the panel discussion now. And I thank all the panelists from my side. And I'll just wind up this panel with a few slides on the WHO Global Initiative for Childhood Cancer, which was mentioned earlier by Dr. Farah, that there is a big impetus from the WHO now to improve cancer outcomes for children globally. And for all the barriers that we have seen in the first presentation and all the reasons why there is lack of delayed referrals and why children born in different countries have different outcomes, it's probably a lot of it is related to late presentations because of lack of awareness amongst parents, physicians, and pediatricians. And that's where educational sessions like today's can go a long way. And together with professional groups like IPA, SIOP, as well as national pediatric organizations, we can slowly achieve this WHO JICC goal for childhood cancer. And that brings us to the end of this session. I'll hand it over back to Dr. Ricana McCurate for the questions as well as the closing remarks.
Thank you very much, Dr. Nita and the panelists for that excellent discussion. A good deep dive into each of those cases of cancers. So it's time for questions. I don't seem to see any question in the Q&A box. I see appreciation. Thank you so much. I don't see any new question. Do we have any questions coming? Please, you can quickly write your question in the Q&A. I do not also see any hand raised at this point in time. So, okay, Kim Zhao, you have your hand raised. Is it possible for him to speak?
Yes, doctor, I can allow her to talk.
Okay.
Just give me a
Okay.
second. He can speak. Please unmute your mic.
Thank you so much for your presentation. It was enlightening and it was educative, and it really has inspired me to understand so much about what is going on globally concerning the diagnosis, treatment, and the policies that are in place to assist those who are having different forms of malignancy. And I want to say thank you for the program and for the organization that has organized this awareness. Thank you. It's just the comment I want to make. I'm Dr. Kimjal John Joe Patrick from Nigeria, Federal University of Health Sciences Teaching Hospital, Azere in Bauchi State. Thank you.
Thank you. Thank you very much, Dr. Kimjal, for the comments and other people who have commented and thanked the presenters. I think at this point, we have come to the end of this session in the absence of any more questions. And I wish to say that the IPA program area on pediatric oncology is grateful. First to the IPA president, Professor Joseph Haddad, for making out time to join us at the beginning as the chair of the webinar. Thank you very much to our distinguished speaker, Professor Ola Farah, and all the panelists for their invaluable contributions. To the participants, thank you so much for joining this very important discussion. And of course, Professor Nita, thank you for that excellent moderation and putting together the session. Now, today's session, marking the September Awareness Month for Childhood Cancer, reminded us that cancer is a leading cause of death for children and adolescents. The good news we hear is that cure is a reality for most childhood cancers, with early recognition from a high index of suspicion and intervention being our most powerful tool. We have used case studies such as persistent fever with hepatosplenomegaly, an unexplained abdominal mass, a white reflex in the eye, and bony swellings or masses to discuss common causes, malignancy clues, diagnostic approach, and referral. As pediatricians and healthcare providers, we are often the first point of contact for children and families. A careful examination, a moment of heightened suspicion, and a decision to investigate further can mean the difference between delayed treatment and early life-saving intervention. Every child deserves the chance at timely diagnosis and access to care, regardless of where they live. Now, we heard from the presentation of a huge gap where more than 80% of these malignancies in developed countries can actually have a cure, whereas it's down to 30% in low and middle income countries. How can we close this gap? A gap that most often is caused by delay in making diagnosis. The discussion today also underscored that beyond knowledge, collaboration is essential. Sharing expertise across regions, strengthening referral systems, and raising awareness within our communities are all steps towards improving outcomes. I believe we learned quite a bit. When not to give steroids before you refer, when not to be doing antibiotics before you refer. I think those were quite interesting points to note in our referral plans. Together, we can help close that gap between early symptoms and effective treatment. On behalf of the International Pediatric Association, I thank you for your commitment to child health and for your active participation in today's webinar. Let us carry forward this knowledge into our practice and continue advocating for the children and families who depend on us. Together, let us turn early recognition into early action, because every child deserves the chance to survive and thrive. Finally, before we go, kindly help us fill the feedback form that has been shared to us. Please, it's important to hear from you about this webinar. Thank you once again, and we look forward to engaging with you in future sessions. Goodbye.
I think few of the participants have asked for the feedback in the chat. So if IPA team could kindly do that.
Yes, Dr. Nita. Once you end the webinar, there will be an automated pop-up for the feedback link, and you can fill the feedback from that, and it will also be shared in follow-up email.
Thank you for confirming. And I think everyone who fills the feedback will also generate the certificate as well. Am I right?
Correct.
Yes, Dr. Nita. Whoever fills the feedback form will receive the certificate of the participation in webinar.
Dr. Farah, you want to say something? I see your hand is up.
Yes, thank you so much. I want to thank you all, Nita, Ekarem, all the panelists, moderators. It was an outstanding session. I really enjoyed meeting also pediatricians from all over the world with one common goal. And I would just like to ask everybody if there are any particular topics that they would like the pediatric oncology section of the IPA to address, concerns for pediatricians, topics of interest to them, to send us the suggestions to Dr. Nita and Dr. Ekanem. And we will be happy to organize more webinars on topics interesting to pediatricians. Thank you so much.
Thank you very much. Goodbye, everybody. Thank you so much to the IPA team for making this possible, all the arrangements, background. We appreciate you. Thank you.
Thank you so much.
Everyone. Thank you to all the panelists and Dr. Nita, Dr. Ekanem. Thank you.
Thank you.
I love what you said, Ekanem. I love the closing remarks. Very nice. It shows maturity in the practice, experience. I really appreciate it.
Thank you very much. Thank you.
Thank you.
And your
Visit
talk was
Lebanon.
excellent.
Thank you. I hope you will come to Lebanon one day, and or us going to Nigeria one day. We should meet in person. You're welcome anytime here.
Thank you. I look forward to that. Thank you very much.
Bye-bye.
Okay, bye.